and we're not. Okay, so the adverse effects occur in patients with other risk factors for arrhythmias, CHF, or other medications that predispose the person to arrhythmias, Lasix, flecainide, amiodarone. Generally, the risk is small and it's balanced by the need for steady pain control. And I can't say that I haven't ever used methadone in patients with CHF, patients who, may have a reason to have arrhythmias, because sometimes it's just the only thing that we have that can really manage their pain. So for patients with on palliative care, we usually recommend a baseline EKG, and the cutoff for the QTC is 450 milliseconds. So if you do your baseline EKG and they're already at 445, I'm going to say, whoops, we're not going to add methadone to this person. If they're at 455, I'm going to say, we might want to discontinue one of those psych meds. So that's kind of where the danger range starts. And then if you do put them on methadone and you're going to be following them over time, you can repeat the EKG every year. You should tell them that there's a risk of arrhythmia and drug-drug interactions at the outset, along with your usual discussion about opioid risk. So we have these start talking forms from the state of Michigan that says opioids are addictive, don't share them with your friends, etc. If you're prescribing methadone, in addition, say there are drug-drug interactions and there's a chance of arrhythmias. Some people say they should sign a paper saying that they understand those risks. That's not specifically listed on the opioid form that we use, but you can write in a little bit, like methadone discussed or something like that if you want. So like all of the medications that we use, it seems to be, they all add together to create sedation. So if you have a patient who's already on Ativan, morphine, Neurontin, and Remeron, can they have methadone too? And the answer is yes. There's no absolute ceiling. It's just based on the patient's response, their drowsiness, their respiratory rate. You give them the usual warnings about driving and using alcohol with the sedating medications. But yeah, you can use it. It's a good idea to ask the pharmacist. If you see a lot of medications on the patient's list that you aren't that familiar with and you're really wanting to add methadone, it would be a good thing to ask the pharmacist, or run one of your drug interaction programs on your phone to find out if there are going to be interactions. If you're adding something like an antibiotic that's only going to be on for a week, try to choose the safer drug, the one that doesn't affect the methadone as much. But if you are expecting an increase or a decrease in your methadone effect, like say you're going to add nystatin for a week and you expect some change in the methadone effects, there isn't really an evidence-based plan for that. Mostly they say just be aware of it and know that it could change the methadone effectiveness. And in addition to all these reasons why your methadone effects are variable, the patient may not adhere to your regimen. They may just decide to use it PRN, or they might suddenly stop it unexpectedly. So you need to educate the nurse, the patient, and the caregivers about the signs of rising serum methadone level or falling serum methadone level. So if you have too much methadone, rising serum methadone level, like say 1 week after initiating the methadone, the patient is sleeping too much, but they're arousable, as in normal sleep. They might be sleeping through breakfast. And they have a lower respiratory rate. So their respiratory rate's not going to be 27 or 30, because a lot of times it's confusing. Is the person just declining, just getting ready to die because of their underlying cancer? Or is this the methadone? So they'll have a lower respiratory rate and they'll have little or no pain complaints. If your methadone is too high, they're not going to be using their PRN med every 2 hours. The progression to myoclonic jerks, hallucinations, followed by a deep coma and death is a slow progression. And usually there's going to be a couple days there where you can catch it. And this is just the opioid overdose syndrome. You can treat it with Narcan, or you can cut the doses, you can take the doses away. And then if you have too little methadone, like the person who's started Decadron and all of a sudden they're not, their methadone is being removed quickly from the system. They can be shaky with tremors, they feel flushed, nauseated, vomiting, diarrhea, sweaty, painful and restless. So like Cara Poland says, the worst flu and insomnia. The worst flu you ever had plus insomnia, that's opioid withdrawal syndrome. So a lot of times people will say, she came in the hospital for urosepsis. And on day 2, she started having vomiting and diarrhea. On day 3, she, and you're like, wait a minute, what happened to her methadone? She was on methadone. Yeah, well, we stopped that because she was sleepy when she came in. Yeah, but she came in with sepsis. Okay, so you stopped it, but she was fine, she was fine on day 1 and day 2. But on day 3 and day 4, she wasn't fine anymore. But there's a little bit of a disconnect because the timing is a little bit delayed. And so people don't always make the connection, just like they don't always make the connection from too much methadone. I've had several times where the hospice nurse calls me and says, okay, we need to start morphine and Ativan on this patient because she's declining now. And I'm like, wow, what happened? Well, she's sleeping all day and she's no longer getting up. She's no longer walking. Okay, but what happened? I just saw her a week ago. Wait a minute. I started methadone a week ago. Okay, that's what happened. Because a lot of times people aren't making making the connection. They're like, oh, she was fine on the methadone for the first 3 days, but it's the 7th day that you need to worry about. So a little bit of a delay there. So the ideal patients for methadone are patients that are a little bit more chronic pain. We don't really want to use it just at the very end of life. We want to use it for people who are have kind of a steady pain. You don't want to give it to someone who's just post-op surgically or going to be getting better in a few days or going to be getting a celiac plexus block, and it's going to make it confusing of how much they really need. So you want to think about the risks for these patients, especially if you think you're going to have higher doses. I don't use it with antiviral HIV drugs, and I don't use it very much in cardiac disease. Liver and kidney disease is okay. It's great for dialysis patients. I use it a lot for dialysis patients. Okay, so for the more visual people, wanted to try again, take a stab at the pharmacokinetics. Still, some people, after listening to this point in the lecture, still seem to have a little bit of confusion about how it builds up and how it decreases. So on the top graph, we've got morphine. On the bottom graph, methadone. Top graph in the red, the little lines are if you're dosing Roxanol frequently, you see it goes up and down, up and down, up and down, but the baseline stays the same. Same with the MS Contin. It's just a slower process, but the baseline stays the same. But with methadone, as you dose it, the very first dose, you get a good effect, but the baseline goes up a little bit and then up a little bit and then up a little bit. So every time you're giving the methadone, the baseline is rising, and that's for about 7 days. So compared to dosing it every 12 hours versus every 8 hours, you just get a little more of a gap in between the peaks for the 12 hours. I like to start it every 8 hours if I have a severe pain situation. If it's just like a low grade pain situation, maybe every 12 hours. But if you're really trying to get the best possible coverage of the pain, I usually start it every 8 hours. So it's going to drop off. Your serum level is going to drop off between every dose. Now, when we start a Duragesic patch, we know the very first 12 hours, they're not going to get that much good pain control. With the methadone, you'll get some pain control, but it will get better and better and better. And it'll continue to drop, but the baseline rises. So if your pain control if you need this much pain control where those orange arrows are to get your pain managed, then you see it takes longer to do it with the methadone. And when you take the Duragesic patch off, or when you stop giving the methadone, it's a simple curve. It goes down just like a Duragesic patch does, just like any other drug. It's not complicated. The way people get mixed up about methadone is if you do something like give Narcan, where you have you have obliterated the effect just for 4 hours or so with the Narcan, but there's still a tremendous amount of methadone in the body, and that's going to come back into the blood level. And or if you do plasmapheresis or dialysis where you're taking it all out of the serum, you still have that huge amount in the body that's going to come back into the body after that. And that's if you've been taking it continuously. If you just have one dose, you haven't built up hardly anything in the body, right? Okay. Opioid rotation is one of those things that we used to do a lot when we gave high doses of opioids to chronic pain patients. We don't do it as much now. But if you have a person who's on an opioid and they're on kind of a high dose, but they have a lot of toxicity, you can actually switch them to a different opioid and get rid of a lot of the toxicity symptoms, the twitching, the myoclonic jerks, various other sedation, especially. So we have a lot of people who like say they tried a fentanyl patch, but it made them too sleepy and they didn't like it. So they want to switch to something else. Estimating the new dose of methadone is not really an exact science. It's just kind of one of those things that you start using the math and then you make adjustments. So we're back to factors complicating opioid conversions. We know that there's a difference with absorption in some cases, like for example, people who put a fentanyl patch on, but they're very sweaty, and there's different metabolic differences and compliance differences and drug interactions. So for methadone, so we're going to switch from another long-acting to methadone. We start with calculating the daily oral morphine dose. And then for patients on a low amount of morphine, less than 100 milligrams a day of oral morphine, we divide by 4. For patients on a middle of dose, divide by 8, higher dose, divide by 10, super high dose, divide by 20. You can get it down to about a 3 sections, but the truth is it's a curve. See, it's a curve. So with those factors, we're making a straight line. We're trying to approximate this kind of curve. I used to use these actually use these a lot, but now I kind of more just go with small, medium, and large. Like it's either 2.5 3 times a day, or it's 5 3 times a day, or it's 10 3 times a day. I usually don't go more than 10 3 times a day to start. And I think this curve, the reason this curve exists is because morphine tolerance at high doses is not, and methadone doesn't really have the tolerance. So for calculating doses, if we're only on short acting and we're ready to add a long acting, you can give a small dose of methadone, Q8 or Q12, and allow them to continue to use their short acting med for breakthrough, and make sure they have a good breakthrough med. I hate it when people say, "Oh, I've already tried methadone. I don't want to try that again. I was on it for a week. It did nothing. It was horrible." I'm like, okay, yeah, but what was your breakthrough? You were not controlling their pain while you're initiating methadone. And so you're bound to fail, especially if you've been very conservative and guessed a 25% dose and you're going to take 4 weeks to get to it. So yeah, you need to have a good breakthrough med. Let them have the one that works. Okay, so we're going to do some cases. Let's see. How are we on time? 8:01. Perfect. Okay. All right, so I'm going to need your input on these cases. So this is a 60-year-old man. He's on hospice. He's got lung cancer. His current regimen is MS-Contin and short-acting morphine. He's got pretty high doses, and still his pain is not that great controlled, but his family says he's sleepy, he's twitchy. He's not going to be able to go up any higher on the morphine. His total daily opioid is 470 milligrams. So he's on a high dose. How would we convert him to methadone? So you can see that the 470 includes the short acting and the long acting. So we put both of those in. And then if we convert that to methadone, would we use a 1:10? We could use a 1:10 ratio, and that would give us what? 47, yes. And so if we wanted to divide that into 3 equal doses,
Said small, would you say, small, medium, large. So we need a large Coke. We need
We
a,
need large. Yeah. So yes, right. So you could do 15 Q8 would be what you would calculate, and then you could say, well, let's just go with 10 at Q8. And you provide the teaching to the patient and the family. And I would like to try and follow up at 3 days and 5 days. It's easy when you're on hospice. It's a lot harder for a palliative care patient who's, not with you. But if you can follow up at 3 days and 5 days, you'll have the best outcomes, because if they're going to have trouble, it's going to be in that first week.
and they would still continue their short acting morphine.
They still continue their short acting morphine, so they have pain control. And they're going to use it less towards the end of the week than they did towards the beginning of the week.
Right.
Okay. So here's case number 2. This is a good one. The facility's called. They've discovered an error. Our 86-year-old man on hospice with prostate cancer, and he's on methadone, and he was taking 1 milligram twice a day, and he's been doing really good on that, but they accidentally gave him 5 milligrams. And they gave it at 8 a.m. and now it's noon and they just discovered it. Okay, so they're calling you, doctor. What should we do?
Monitor.
Well,
What do you need to know?
is he enjoying it?
So what, how is he doing, So what they say, oh, he's in the lunchroom eating lunch and chatting and talking with the other people. He seems fine. Okay, so what should we do? It's been 4 hours since he got the big dose. Is he getting the full effect already? Yes, he is. He has already absorbed it. He's already gotten the full effect. He's probably up just past the peak and coming down. So do we need to worry that he's going to all of a sudden become sedated? No, he's already absorbed it. He's already peaked. He's already coming down. So is his blood level going to continue to go up, up, up? No, it's not. So what we need to do? Probably nothing. He's okay. Just be a little more careful with your medication administration at the facility. You could hold his mid-afternoon dose, maybe.
Well, because now his fat level will be higher, but then his acute access, I guess, will come from the fat. I'm just thinking
Yeah.
if he's only 1 BID, you just gave him 2.5 days worth, right? In one dose.
Yes.
And he's tolerating it.
Yes,
But then he almost has a depot of the 1 BID for.
right.
Right? I mean, you'd want
Has a
to
depth.
hold at least.
You could hold one dose if you wanted to.
Yeah.
But what I don't want you to do is say, give him Narcan. Because I had a patient this happened to. They called the facility doctor instead of me. And she said, give Narcan. And they gave him a big slug of Narcan. He went into a pain crisis. And then he started having chest pain and he had a heart attack. And that was not nice. He did not need that. He did not need that. And
Does
so
not need that.
if you're going to give Narcan to one of our patients, please give a small dose, small dose, small dose. You don't need to give it all at once. Give them a little dose, give them a little dose, see what happens, okay? If they're not in immediate danger. And this guy didn't need it at all. Okay, here's another case. Patient has taken almost a whole bottle of pills. He was on 5 milligrams twice a day. He was on hospice for lung cancer, and recently he's expressed depressed feelings. He's burdening his daughter. Daughter just went to work, but the social worker showed up and he is found, has apparently taken an overdose. It looks like he's taken 16 pills of his 5 milligram methadone less than an hour ago. What do we need to know? What are our concerns? What should we do?
Is he breathing?
So what condition is he in now? The condition is he's sleeping and we can't wake him up. He's laying there snoring. He is breathing, but he's breathing about 10 per minute and snoring. He doesn't wake up when we shake him or pat him. So what do you think? What do we need to do? Is this dangerous? Will he be okay? Should he just sleep it off? It's less than an hour ago. Has he absorbed it all yet?
No.
It's dangerous. He hasn't even probably absorbed it all yet. And he's going to go higher than where he is now. He's already kind of in a low-grade coma at this point. So some people would say, okay, he needs to go to the ER. He may have some pill fragments in his stomach. We could pump his stomach, give him charcoal and, blah, blah, blah. And you might decide to do that. I mean, I would say call his daughter and see what she says. But, you might say, well, let's just start giving him Narcan. Maybe we could do continuous care for the day at home. He's gonna need more than one dose of Narcan because he's got a large amount in his system, and it's gonna take all day probably to get through this. So he can either go to ER, where they would probably start like a continuous Narcan infusion, or he can be at home with maybe continuous care or the nurse standing there giving him Narcan every 3 hours or so until he gets through this. And then, of course, we're going to need to put some new safeguards in place to keep this guy safer. So we're going to need to mostly talk to him, figure out what he was thinking and what's going on. And the social worker can certainly help a lot with all that management, but we might need to switch him to a different plan where he doesn't have access to the whole bottle, where the daughter's putting out the pills for him, or where he's on a fentanyl patch, which is harder to overdose on. Some other safety plan. Okay, another case. This is a lady with esophageal cancer, and she's been on a Duragesic patch, but she complains of pain with swallowing and a new burning pain and numbness going around the ribs on one side of her chest. Her pain is inadequately controlled using 20 milligrams of Roxanol every 2 hours and rating her pain at an 8. So she's taken 8 doses in the last 24 hours. And she's on a huge Duragesic patch. I don't think we ever get up to 200 micrograms anymore. But what do you think about when you think about maybe rotating to methadone for her?
Well, first of all, this is, the burning pain suggests there's kind of a neuropathic component.
Right, sounds neuropathic.
And how are you going to address that? And it's obviously an NMDA agonist. That would be a choice, and hence methadone comes to mind. So that's the rationale behind using methadone and moving forward.
Also, you might want gabapentin or something else like that if she doesn't already have that. Also, I wonder about her absorption of the Duragesic patch. That seems like a really high patch. I'm not sure she's getting it. How skinny is she? Because you really need to have like a 1/4 inch of fat under the patch to make a nice depot. And if you don't have that, it's very unpredictable how well the Duragesic is going to work. Also, they might be saying, oh yeah, she sweats all the time, but we stick it on with tape or something, and then you're not getting an adequate
But something,
patch too.
I mean, this, in the last 24 hours, she's now doing 8 doses of her immediate release.
Yeah,
So like something has like gone south either.
yeah, either the tumors just bust through
Yeah.
somewhere or something, so she's definitely needing.
Opioid induced hyperalgesia. I mean, I don't think it happens that fast, but it's sort of like, it's time to change course.
It's time to change. I think an opioid rotation would be great for her, so.
Or she needs some pons on her ribs.
Yes, pons on the ribs. So we would definitely ask about the patch adherence. Was the patch really sticking, or was there really is there still fat on this patient? Trying to figure out if this dose is really the dose to base our methadone conversion on. It sounds neuropathic, and methadone does do better for neuropathic pain. I would also probably add some gabapentin if she didn't have it already. And so how do we convert a patch to oral morphine equivalents? Because we want to calculate, right? So we use a rough estimate of 1 to 2 or 2 to 1 to convert Duragesic to morphine. So this is, it's a rough estimate, but this is what we use. So if you're on 200 micrograms per hour of fentanyl, it equals 400 milligrams per day of morphine. So the units are not equivalent, right? So when you're using a fentanyl patch, you're using micrograms per hour, similar to the IV fentanyl, which is micrograms per hour. And in fact, those two are pretty interchangeable. But when you switch to morphine, when you're trying to calculate it, you go 1 to 2, and then it's milligrams per day of oral morphine. And then plus the breakthrough, the total estimated morphine equivalence is 560. We convert 10 to 1 and you get 56 of methadone.
But there's also the assumption that
But we don't
That
know how
fentanyl
much
is
of that
actually
fentanyl she was really absorbing, so we would definitely cut it down. Yeah.
Mostly because if she had 200 in the background and she's using all that Roxanol, it's probably because like maybe she could eat zero of the fentanyl and the Roxanol really represents
What's
her
really
opioid
working.
control. You
Mhm.
know what I mean? So,
Mhm.
you know, that could almost be her day. I mean, she'd get probably a little bit from the fentanyl.
Yeah. Well, we're not getting any forwarding of the slides. Okay, here we go. We're gonna use a different button. All right, so here's another case. This is a guy who had metastatic melanoma, pain in his groin and hip socket, severe pain, but it was incompletely treated with frequent Vicodin and caused him nausea. The hospice team put him on a fentanyl infusion. What were they thinking? And they got him comfortable at home, but the family thought he was too sleepy on it. They didn't like it. And they didn't like the idea that it was fentanyl. Then he was gonna go assisted living, and the facility, of course, didn't take patients with pumps since they called from the house. Can we convert the patient immediately to something else? What should we do? He was on the 75 microgram per hour infusion. We could easily go with a patch, but they're like, no, we don't like the fentanyl. That makes him too sleepy. So, okay, but it is controlling his pain. So again, how many morphine equivalents? He's on 75 micrograms per hour. 150 milligrams per day, yes. So we discussed it. We couldn't have the pump at the facility. He didn't tolerate the different short actings that he had tried. So we started on 5 milligrams of methadone Q8 hours and 5 milligrams Q4 hours PRN because he didn't have a good PRN that was working. He was transferred to assisted living and this worked well for him. I want to talk about using the methadone as a PRN for initiating. There were a lot of different ways of initiating methadone when we first started using it for pain. Some people said to just use it PRN for the first 3 days and then figure out how much you're using and then make that your steady state dose. So there were a couple different protocols that were tried. I would say this works pretty good if you have a clear difference between the scheduled and the PRN. So if you say scheduled Q8 and Q4 PRN. So if it's a patient at home, family gets very confused. They give 3 doses and then he seems fine, then they don't give any for 12 hours and then he's in a pain crisis. So you need to go the scheduled, which is what you think they need, and then the PRN for mostly just the initiation phase, and hopefully they won't really even need it. If they end up needing 4 doses a day, your schedule plus 1 PRN, then maybe you might make an adjustment to your schedule. But probably, this is a good way to get people going on methadone when they haven't been on it, on any, good breakthrough. Okay, well, these pictures are going off the side. Okay, so here's another case. This is a 60-year-old patient. She's been on Percocet for chronic pain, back pain and shoulder pain. Her prescription coverage is terrible. Her overall health is declining and she's expected to have less than 2-year prognosis because of renal cancer. She's recently been taking up to 8 Percocet a day. So I have a lot of patients who just want to take more Norco or something. They're on 4 a day, but they want to take 5 and they want to take 6 and they want to take 10. And so in this case, I would like to initiate a long acting. But even though she has renal disease, that's not going to be a problem. We're going to be able to use the methadone, right? Oh, wait, I'm going back. So what would we do for her? What dose? Using 8 Percocet a day of 10/325 milligrams, so that's 80 milligrams a day. So we could divide it by 4. What would that be? 20. So if we divided that into 3 equal doses, that would be 15. Again, you see, it always comes out to somewhere in the same range again. So you could give her 5 BID and kind of see how that goes. All right, so here's another situation. A lady in a nursing home or assisted living. She's got pain from spinal stenosis and arthritis. Pain just goes down the legs, really fragile health. She's been taking Motrin 3 times a day and Tylenol and Tramadol. She can only tolerate a half tab of Tramadol. The full dose of tramadol or the hydrocodone caused lethargy. 100 milligrams of gabapentin was too strong for her. Can we use methadone? And if so, what dose? So she's basically stuck. She can't get on an opioid. And if we started her on 15 milligram MS Contin, we would blow her away. So the good thing about methadone is it does come in really small doses. The smallest tablet is 5 milligrams, but it comes in liquid, and the liquid is 1 milligram per ml. For some reason, they call it 5 milligrams per 5 ml. Not 5 milligrams per ml, but 5 milligrams per 5 ml, which is a dumb name and it causes drug errors, but it is 1 milligram per ml. And so in her case, I would start 0.5 milligrams Q12. And for people in nursing homes, that seems to be a good starting dose. Elderly patients. And so if they're on short actings, but they don't have good control, I would start 0.5 milligrams Q12 and see how that goes. And then don't double it, maybe go up to Q8 if it doesn't seem to be quite enough. Okay, let's go back to our questions again and see if we know the answers now. Number one, how long does it take to get to max blood levels when starting methadone?
4
Right, 4 hours, but how about the long acting? If you're starting on a steady regimen, 7 days, all right? 5 to 7 days. Okay, what if someone takes too much methadone, they're on too much methadone, what do they look like?
Depends on how much they took. Could be nothing, they could be dead.
Yes, okay.
Anywhere in between.
So somewhere between over sedated and, yeah, right. So if you've guessed a little bit off and you've got them on too much methadone, they're gonna be sleepy and maybe twitchy, and you can cut back. And then how can methadone be both short acting and long acting?
It's a miracle drug.
Because it's a miracle drug. It has those two compartments. And then how do we convert morphine to methadone? 4-to-1, 10-to-1, 20-to-1, all of the above. All of the above, yeah. Why do they use methadone to treat addiction? Well, it's long acting, it can be dosed once a day, all that kind of thing. Now, I think they're using buprenorphine more and more and more because of the limit on the respiratory depression. Why is methadone a superior long acting at the end of life? So if you have a hospice patient, what's good about the fact that they're on methadone when they're getting into that imminent phase?
Renal function.
The renal function doesn't matter, and you can keep giving it. You don't have to stop it because they can't swallow anymore. What kind of pain patient would benefit from methadone? We know that, right? Now, chronic pain, neuropathic pain. Okay, and what are the warnings to keep in mind? The QTC.
The hypothetical QT.
The QTC and the drug
It's
interaction.
real, but does it matter? Right?
Matters
It's
if you're
real.
dead.
So
So,
no, but I mean, like the actual clinical significance of a long QT in these patients has been not really shown to be much.
it isn't,
I mean, like, it extends it.
it is theoretically a real risk, but it's just, we haven't seen it be
And if I did an EKG on you today and I did an EKG in 30 days, you would be longer, but would you have any more like bad outcomes?
really
And
be
it
bad.
really doesn't show that. So
right. So there are some people who have had bad outcomes on the methadone, but I would say it has more to do with the interactions with other drugs, making the QTC all of a sudden a lot longer. But anyway, yeah, so it's complex pharmacokinetics. There's a lot of potential for this and that, different routes, but it has a lot of benefits. It's like so easy to get on board. It's absorbed well, it's lower cost, it's got longer intervals of administration, it's got no active metabolites, rapid onset, long half-life, more favorable side effect profile, low rate of induction of tolerance, more effective for severe pain. In fact, I just really love methadone a lot.
and it's cheap.
And they're cheap, yeah.
Why isn't it used like for every?
We don't know.
Yeah, on my service it is. Right.
I mean, just across the board. I mean.
Well, like
I'm-
if you go in the hospital and you've got a new cancer diagnosis and you've got pain and they put you on the usual stuff they put on in the hospital. And then they say, okay, now you got to go home. We go from IV to Dilaudid. Well, they'll say, let's put you on MS Contin because they can see the effect right away. If you're initiating methadone, you have to have a hold of that patient.
Yeah.
You have to keep, if they're gonna be under your control. Also, methadone, like I said, not everybody's comfortable with it. I don't usually start it on patients if they're going through cancer chemotherapy and they're gonna have cancer surgery and they're, because then there's a lot of other doctors who have to feel comfortable with these medications. Same with buprenorphine. If they're gonna have even a procedure or a surgery, the doctor's gonna call you and say, what are we gonna do with the buprenorphine while the patient's going through this?
Or stigma then.
It's because you may be the only one who knows how to manage it. And, so the other doctors may have a hard time with it. So I don't put everybody on it. And when they're on hospice, that's my favorite long acting for our hospice patients, really, because nobody else is gonna be, worried about it. And, it just works really well. And like I said, at the end of life, they can keep taking it nice and steady. So
Okay.
that's a lot of good. And our goal is happier patients. And that's the end. Thank you. Are there any questions?
I had a question. Because I think it's legitimate about the confusion in the home setting. If you told them, here's your 5 methadone to take scheduled and your methadone to take PRN and
PRN,
they
yes,
start giving it all PRN.
yes.
What about,
Yeah.
Aaron and I have talked quite a bit about methadone, specifically because of the sublingual activity of it, which is even better than oral. Is what if they had tablets for their schedule and liquid for their PRN? The family would know the liquid was PRN. You always give the tablets. And then you just give them a little liquid under the tongue when they're having a breakthrough pain. And the family knows, like, I just,
I think that sounds really nice, but I think that's a little bit complex.
Okay.
And I found that anytime you make it complex, people get a little bit like, oh, what am I doing? And when I used to try and taper down the other long acting and then increase the methadone, and I got so many calls, even in a facility, even in the hospital, even though I wrote it all out, they were always like, oh, and they call.
Okay.
So, making it complex has its own, negative effects, but yeah, I mean, it would be nice to make it simpler for people somehow, and however you can do that. Like put that Q8 in the med box, and then have the bottle, give them the bottle with
Yeah.
the 2 in it that they can take sometime during the day if
Yeah.
they need to.
well, and I was thinking like if one was liquid and one was tablet, like simplifying it for patients.
Uh-huh.
Like they can't even, they can still mess it up, but it's like, oh yeah, I give mom the tablets every 8, but it's the liquid I use when she's having breakthrough.
Mhm.
And I don't know.
Yeah, so most of the time we have already a good breakthrough med. So whatever their good breakthrough med is that they've been using, we let them keep using that.
In the case of like oropharyngeal cancers or esophageal cancers,
Mhm,
do you think they're, in using liquid in particular,
mhm.
do you think it's that topical effect? Is
Mhm.
it the sublingual
Mhm.
also, even if you're not having them hold it in their mouth? It just seems to be.
It does give
the
you
liquid
a topical
works.
effect, yes. So
okay.
if you have mouth sores, morphine swishing around in your mouth before you swallow it works better than just swallowing it. So there's definitely a topical concentration. And esophageal cancer, I agree, it's great for that. And that's just a really severe pain that's hard to manage otherwise. Any other questions?
Would we ever dose it QID, you think, as a schedule?
So every now and then I get patients who, mostly in the hospital, who say, or outpatient too, where they say that every 8 hours is just not enough. And they're usually the more severe pain patients. And so, yeah, they can take it every 6 hours. For whatever reason, they seem to be churning through it faster. I wouldn't say they can't have it just because my pharmacokinetics in my head say that it has to be dosed every 8 hours. Most of the time, those are people who have a prior history of substance use disorder. I find that in the hospital, the people with substance use disorder want a lot of extra opioids to the point that they're asleep. And when they wake up, they ask for opioid. And that's very hard to manage in general. Because they're never happy. But yeah, so you can give it every 6 hours. I wouldn't give it every more than that on a schedule.
Yeah.
Well, awake equals pain.
Yeah, like being awake,
Yeah.
the fact that you're not asleep is too much to bear.
Well, I think there is a like that Eric Clapton song, going down a dead end street on your hands and knees. That is what happens to people with chronic opioid use over years, is that they end up with a smaller and smaller window of comfortable and awake and functional. It goes from, 4 hours down to just 5 minutes, so comfortable, awake and functional is what you hope to get with your opioid. But if you've been on opioids for years and years and years, I think it disappears. That window closes up on people.
You find the same with, as we're talking about the liver enzymes are chronic alcoholics because their enzymes are ramped up, like when you dose propofol to a liver.
They can take a lot more,
I
yeah.
mean, you can give them like a lot of bottles, so I'm just like wondering if, with the you talk about with the Decadron can get it to like.
Yeah,
I'm just curious in your.
so a person who has higher tolerance of alcohol would also probably, take higher doses of,
And obviously not people probably with end-stage liver disease. But
that's why when I talk about the guy with the grapefruit juice, I say he was a tough guy with a lot of tattoos. I was picturing, he was a drinker, smoker, whatever. I was picturing he was gonna tolerate every dose.
And he's like, I actually just started drinking grape.
Yeah, so that. Okay.
Healthy, starting today.
Any other questions out there before we transition to the case?